Okay. All right, Alex. So tell me a little bit about your practice and how you guys have introduced and brought ultrasound into various aspects of your practice. You know, pre-op, during, and post. How has that gone over time?
When I started at my group 5.5 years ago, they were fairly infantile with their use of ultrasound. A girl that had graduated residency shortly before I did had come to the group and had gotten them more or less their first ultrasounds and got them started. Yes.
I'm sorry. I just wanted to point out, just for you, um, it's not to be politically correct, but
Yep.
you said girl, and
Oh.
somebody might go, wow,
Yeah.
you know what I mean? So
Yeah.
just
I say it because it's hard because she was a friend of mine. So
Okay,
when I
yeah.
think about her, I don't think about her as like a colleague.
Yeah,
It's like,
no, I
yeah.
totally get it.
Yeah.
But anyway, if you could start again.
Start from the beginning?
Yeah.
Sure. So when I started my group about 5.5 years ago, they were still pretty infantile with their use of ultrasound. A colleague that had started a few years before had gotten them their first ultrasounds and kind of started to get them up to speed. I was actually primarily brought into the group having done a fellowship in regional anesthesia and having trained more or less primarily with ultrasound. My fellowship still overlapped the days when nerve stimulator was still in use, so we were kind of doing a combination of ultrasound guided and nerve stimulation. So the intent of me coming into the group was to sort of bring the group up to speed, which I did over the course of the first couple of years, getting all of my colleagues comfortable using ultrasound, introducing blocks that were regional anesthetic techniques that are available only through the use of ultrasound, so adductor canal blocks, tap blocks, PEX blocks, things of that type. And also starting to work to get buy-in from the surgeons on those type of post-op pain control techniques, both that they can be effective and also that it can be not too time-consuming as far as OR workflow goes. So it was a process of a couple of years, like I said, to get my group up to speed and to get surgeon buy-in, but now having been there 5.5 years, we're have a fairly robust regional anesthetic program using the ultrasounds.
So tell me a little bit about that surgeon buy-in. What did you have to show them in terms of like the efficacy, and how did you evolve? How did they evolve over time? Obviously, they're scientists too, and they want proof. They're cowboy scientists.
Yeah, they're different. I mean, surgeons, you can present the data to them, and I think that helps. But surgeons tend to be a little more anecdotal. I mean, they like to see it in real time. They like to see it, how will it actually integrate into the workflow. So the efficacy, I think you can prove to them showing data, and with the first few blocks you do, patients reporting less pain, good patient satisfaction afterwards. But as much as anything, it was proving to them that ultrasound, not only can you do techniques like tap and PEX that are new and interesting and exciting, but that it sped up other nerve block procedures. So we had orthopedic surgeons that were totally against blocks when I first got there, and the main reasons, they would give other reasons sometimes, but you could tell the main reason was that they took too long, because the old nerve stimulator techniques sometimes could take 20, 30 minutes to do a block. And so I was able to prove to them over a couple of years, saying I can turn these 20, 30-minute blocks into a 3 to 4 minute procedure. And so they were more receptive to regional anesthesia in general, because the ultrasound speeds up those procedures so much more, and they didn't see that delay in their workflow. By the time they were in the room, the patients were blocked and either asleep or a spinal was on board and everything was ready to go. So.
Wonderful. Speaking of speed, recovery time, and in addition to the workflow and recovery time and so forth, patient satisfaction, the tie-in with patient satisfaction. Does that recovery time and patient satisfaction and the fact that they're not so groggy and they're having to spend more time in the clinic recovering. Do you see that as one of the factors in patient satisfaction?
Absolutely, yeah. And you also see it with feedback we get from PACU nurses and kind of watching how the workflow goes through. Noticeable difference in the length of time patients are spending in PACU. We noticed very early on going around and doing post-op rounds the next day, a much higher percentage of patients reporting. The first question we usually ask on post-op rounds was, how did you do overnight? It's just sort of a good open-ended question to get a sense of were they happy, was pain controlled, nausea and vomiting, those sorts of things. And we found a lot more responses of, I did great overnight, as opposed to varying complaints of pain or nausea or those sorts of things.
So we've talked with some of your colleagues about post-op and your role expanding in post-op using ultrasound. Can you, looking at, is it bleeding, leftover occult blood, whatever it is, could you comment on how ultrasound has helped you or not help you, help the patients in post-op, and also just like your role in the team expanding into that area more?
I think, are you speaking to like point of care ultrasound kind of stuff?
Point of care ultrasound,
yeah.
Post-surgery.
Yeah, so looking, it's something we're currently starting to bring into use as far as exactly the things you said, looking for post-op hematoma formation, looking for potential pneumothoraxes, which can be a complication, a surgical complication, or a regional anesthetic complication, depending on your techniques. Now, pneumothoraxes from regional anesthesia have decreased considerably since the use of ultrasound has come around, but sorry.
We're gonna have to start that again.
Yeah.
Don't worry.
Didn't realize it was still on. Hold on.
Actually, I'm gonna have to take your phone away from you.
Yeah, that's fine.
That can
Here, I'll
a little bit.
I'll just turn it off.
Oh, sure. Yeah.
I was like, nobody's gonna call me, but of course it was my wife.
Yeah, of course. Yeah. Okay, thanks.
There you go.
I'll
Yeah.
give this back.
That's fine, yeah.
Okay. Yeah, so let's go from the top again, particularly with, post-op and what, how it's helped with clinical quality, heading off problems, and also expanding your role in your practice and helping round out your role in the whole teamwork piece of it.
Sure. Yeah, a big push in our particular group is expanding into overall perioperative medicine, sort of perioperative surgical home. And I think a big part of that is expanding our role in not only through PACU, but also going into postoperative care on the floor. And point of care ultrasound is showing promise in that for screening for pneumothoraxes, screening for potential hematomas, even branching out and using smaller ultrasound devices in a TTE kind of fashion, just getting general senses of volume status and wall motion, cardiac wall motion. So all of those are areas that are sort of new for anesthesia, but is important as we're developing our role as perioperative physicians to, not just be in the OR or in the immediate recovery area, but using techniques and devices like ultrasound for other uses.
I'm going to move the microphone up just a pinch.
Yep.
Okay. All right. Okay. Perfect. What is that? I mean, on a personal level, being able to do more. Ultrasound enabling your own professional satisfaction. Can you have any comments on that?
Well, I think anesthesiologists, you can sometimes fall into the trap of almost being just a technician when you are just stuck in the OR. Obviously, there's lots of medical decision making and those sort of things that go on in the OR, but I think in expanding our role, outside of the operating room is important. We are one of the few physicians that really deal with all body systems every day. And I think that puts us in a unique position to continue to follow all of those systems and processes beyond the operating room.
Okay. And what are you doing, so post-op, what are some of the applications of ultrasound that you're using, point-of-care ultrasound in that post-op situation? And could you give possibly an example of something that you maybe typically see that can really change the outcomes, whether somebody recovers quickly or ends up in a nursing home, because something's happened, where the use of ultrasound has enabled you to see something and perhaps intervene in time before it alters that outcome significantly.
Alex, have you guys really fully started doing?
No, I was going to kind of interject
okay,
and say we
okay.
haven't really done much
You're
of
not
that.
there
So
yet. Okay, all right.
it's kind of in the works. Our chairman got promoted to head of all perioperative medicine, so he's
Okay.
kind of starting that process, but we're not using it that much yet.
Okay.
Yep.
All right. So what are some of the other applications that you are using ultrasound for in your practice throughout the continuum? What are some of the more important things that you're doing? Maybe some of the more cutting edge things.
I mean, primarily we're just using it for nerve block procedures, both preoperatively, intraoperatively, postoperatively. We've expanded to doing pain control procedures on the floors as well. So sort of recovery techniques. One of the more interesting applications we use it for was a gentleman had developed thrombosis post-cardiac surgery, phenomenon called HIT, which is heparin-induced thrombosis. And he was showering clots into his arms and was losing blood flow in the arms. So we actually came around and did ultrasounded guided blocks on each arm, and the sympathetic block you get from the nerve block actually opened up some of the blood flow. He ultimately ended up having some amputations on one of his arms, but the other arm we more or less saved by use of that block. So it was an interesting, different use of an ultrasound guided technique. And he was on anticoagulants at the time, so the ability to do those nerve block procedures was only, we were only comfortable doing it because of the ultrasounds we have and the resolution we have on new ultrasounds so we can exactly miss all vascular structures.
Speaking of advanced visualization,
Yeah.
over time, what have you seen in terms of the ability to see finer structures and to be able to use this and really be confident that you're guiding things properly? Has the technology really advanced a lot?
Absolutely. The biggest difference, I think, that I see in my practice is the ability to visualize deeper structures clearly. Obviously, with the new ultrasounds, the overall resolution has gotten better and the clarity of the picture has gotten better, but in our current society where obesity is becoming more and more prevalent, the depth of the structures you're targeting for nerve blocks or the structures you're trying to avoid, like vascular structures, continues to get deeper and deeper. And a block like an adductor canal, where with previous generations of ultrasounds on certain patients, the block just wasn't feasible, or tap blocks being the same. At a certain depth, your picture was not good enough to safely do the procedure, or you were finding you needed to use more of a curvilinear probe, which again can sort of make the procedures more difficult just because it changes the orientation of the structures. So to be able to have very clear, defined targets at greater depths, for my practice, I think has been the biggest change.
Where do you think the use of, I mean, in the context of the opioid crisis and the pressures on practice management to get people up and running sooner and not be groggy longer, or even start them on the path of opioid use, right? Where do you think nerve blocks and the use of ultrasound-guided nerve blocks is going? And do you see an education curve where people are going to start to really understand that this is the way to go? And how do you see that being adopted over time going forward? Obviously, you guys are on the cutting edge of that, and your colleagues around the country and around the world will probably follow. But where do you see that going, and how fast?
Yeah, it's definitely, I mean, it's here. It's been talked about as sort of the future, and the future is definitely now, as far as both limiting opioid use given the opioid crisis. I mean, we're seeing, the most common narcotic medication we use is fentanyl, and you're seeing fentanyl starting to make its way out into the public. So any way we can limit that narcotic use perioperatively is going to be important. But I think primarily the push for same-day discharges for surgeries that typically had been at the very least an overnight stay, if not 2 to 3 day stay, is something we're pushing for in our own group. In particular, we're starting to roll out the same-day total joint program, and a vital part of that is our effective regional anesthesia techniques. Because you need your blocks to work, but you also need them to work with the least amount of volume possible. In those scenarios, the surgeon is also typically injecting local anesthetic in and around the joint capsules themselves. So ultrasound allows us to do an effective block with the least amount of volume, which then allows the surgeon to use his own volume of local anesthetic to give the patient the best result. Another scenario is we have been doing some same-day robotic hysterectomies, and we've been doing tap blocks for those to aid in pain control. It aids in better respiratory mechanics afterwards. Patients are able to get up and move sooner and be comfortably discharged home same day for, again, a surgery that typically would have at least been an overnight stay.
Okay. So one thing that kind of occurs to me that if you have a nerve block and you're not using as much narcotics and so forth, not just talking about addiction down the road, but even maybe time, how long it takes during surgery, there must be some factors where there's a patient safety element of this beyond just the use of narcotics, or maybe even during patient recovery, there's some kind of a factor having to do with, longer times not moving and being up and running, blood pooling, whatever it is. I don't know. This is, sort of the question for you. What are some of the patient safety aspects of using nerve blocks? Not just the, not just the opioid use, but are there anything, other things that are factors?
Well, the reduction of opioids is a huge patient safety factor. The side effects of narcotics, from respiratory depression to increased delirium to increased post-op nausea and vomiting, to delays in PACU due to the time required to get pain under control, and then once that pain is under control, treating those side effects of the narcotics. Patients often require say phase 1 recovery as opposed to phase 2 recovery, because they need closer nursing supervision because of the side effects of those narcotics. Sorry, lost my train of thought in the middle.
Okay.
I had another point I wanted to make.
Sure, we could just make that point.
Make a
We
cut
have
there.
a place where we have a cut.
Yep.
I heard, we're fine.
Yeah. The another patient safety factor is the increased incidence of OSA, or sleep apnea, patients that we're seeing. We routinely screen all of our patients preoperatively using a stop-bang questionnaire, which is a screening tool for suspected sleep apnea in patients, even if they have not been diagnosed with sleep apnea through a sleep study. And what we're finding is a majority of our patients are screening positive for sleep apnea, regardless of whether they know they have it or not. And those patients are, again, prime candidates for regional anesthetic techniques, narcotic sparing techniques, which allow for better recovery, less risk of respiratory depression, respiratory events overnight, and less need to go to specialized care units that are needing to do continual, capnography monitoring overnight because of the concern of, over narcotic use.
We have our iPhones sticking in our pockets. We use them more because they're handy, et cetera. Point of care ultrasound, handheld. How is that how does it sort of like make things easier for you?
The handheld ultrasounds? Yeah, we're in the process of considering buying a few handheld ultrasounds ourselves, and the main uses we're seeing for them would be we plan to have one up in OB to use as a guidance tool for neuraxial techniques on what would otherwise be difficult patients for those techniques. So particularly in the obese patients where it's difficult to feel the bony landmarks to do epidural or spinal techniques. The sort of handheld bedside ultrasound can be used to assess your midline, mark off your midline and use that as a guide. So even if you don't necessarily use it for real-time guidance during the procedure, it can at least give you a sort of a roadmap toward those procedures. I think they also would have some utility we use ultrasound a lot for vascular uses, so we get called to ICUs to start arterial lines, or we get called to floors or to the pre-op area to start IVs on difficult IV sticks, and I find myself just taking my ultrasound with me all the time. I think a smaller portable handheld unit would work well in that sort of scenario. So we're definitely in the process of securing some for those purposes.
Jody, any thoughts?
Yeah, even though I know you touched on it, Alex, can you talk about what role nerve blocks play in enhanced recovery after surgery? So saying, like for tap blocks or PEX blocks or what have you, just how they do help
Mm-hmm.
enhanced recovery after surgery. So if you could use that term,
Yeah.
That'd be great.
Sure.
Alex, can you just go like this? You've got a little bit of sweat. Just kind of, there you go.
Oh yeah, get all shiny. Okay.
Okay.
Yeah, another definitely a big push in our group, and I think in anesthesia as a whole is toward enhanced recovery type protocols, and those bring in many factors, fluid maintenance and multimodal analgesia and those kind of things. But ultrasound definitely plays a big role in those enhanced recovery protocols. Regional anesthesia is a prime factor in those both for pain control, also for limiting post-op nausea and vomiting, decreasing respiratory issues post-operatively. And the types of surgeries that lend themselves toward these enhanced recovery protocols, which are typically the larger general surgery and abdominal type procedures, those regional anesthetic techniques basically require ultrasound to be done effectively, safely. So things like tap blocks, PEX blocks, rectus sheath blocks, I think are a vital part of enhanced recovery in limiting post-op pain in those patients.
Okay. Yeah. Anything else you'd want to imagine? You're every med student, resident, anesthesiologist out there, and you could send them a message. What would you say about the use of ultrasound in general in your practice?
I mean, what I usually tell people is my training is old enough to have spanned back to the days when nerve stimulator was still in common use. I think ultrasound has radically changed regional anesthesia, both from a safety perspective and from a speed perspective, being able to do many more regional anesthetic techniques that we previously were not able to, but also being able to do them faster and more effectively than ever before, and that's even happened just in the last 6-7 years.
Great. Super.
Okay.
It's really nice, Alex.
Cool.
Yeah.